brings together 30,000 oncology professionals from around the world to discuss and report on new therapies, ongoing controversies, and the latest groundbreaking research. I'm Shelby Monier, Director of Education at the Melanoma Research Foundation. I would now like to introduce our host for today's webinar, Dr. Lynn Schuchter. Dr. Schuchter is the Professor of Medicine and Director of the Melanoma Program at Abramson Cancer Center, University of Pennsylvania. She is the past chair and current member of the Scientific Advisory Committee and a former member of the Board of Melanoma Research Foundation. She is a past member of the ASCO Board of Directors, recent past chair of ASCO's Cancer Research Committee, and chair of the Scientific Program Committee. Dr. Schuchter, welcome, and thank you for providing this update for us.
Thank you, Shelby. It's my pleasure to report on the clinical trials that were reported at ASCO. I'm also going to mention a study that was reported at AACR, which is another cancer meeting where exciting results related to melanoma are presented. So we do this webinar every year. Shelby mentioned what ASCO is, but it is the leading cancer meeting that we all attend to hear the latest advancements in the treatment of different diseases. And there was certainly a lot to be excited about in the area of melanoma. So there was a lot of exciting melanoma research presented at both ASCO and AACR. So let me review what we're going to talk about today. I'm going to focus on three different areas. One was a paper on the role of prevention of skin cancer using a vitamin called nicotinamide. This is for prevention of non-melanoma skin cancers, basal cell cancer and squamous cell skin cancer. I'm going to talk about an abstract that looked at the question of the role of completion lymph node dissection in patients with a positive sentinel node, patients with stage 3 melanoma. And then I'll focus most of the time on updates on the treatment of patients with metastatic melanoma or stage 4. And it's an update on the PD-1 therapies. This is the new immunotherapy that we're using in melanoma. And then an update on combination targeted therapy. So something for everybody. So the first paper was presented by Dr. Andrew Martin, and he led a large trial done in Australia. And this is using oral nicotinamide, which is vitamin B3, to reduce actinic cancer. And actinic cancer means squamous cell or basal cell. And the precursors to those types of skin cancer are actinic keratosis. So many patients with melanoma also have these non-melanoma skin cancers. So this is the first report. It's called a phase 3 double-blind randomized controlled trial. That means some of the patients received the vitamin and some did not. So the background from this is that nicotinamide is derived from vitamin B3, which actually is in a lot of grains. It's in Wonder Bread. And there's been interesting preclinical data and other data to suggest that this vitamin may play a role in preventing skin cancer. It can reduce suppressive effects on the immune system associated with sunlight or UV radiation, both UVB and UVA. And previous studies had shown that when it's used topically or as a pill, maybe it would be helpful in preventing skin cancer. And this is a typical design of a trial. So they take a certain group of patients. In this case, it was about almost 400 patients. They had to be at high risk for skin cancer. So they had greater than 2 non-melanoma skin cancers, either basal cell or squamous cell. And they were randomized then to nicotinamide, taking that twice a day, versus a placebo. And what the results showed was that this was a very safe and it's certainly an inexpensive approach. So taking this vitamin really cost only about $10 per month. And it reduced the risk of skin cancer by 23% in patients who were at high risk. It had a similar effect against both squamous cell skin cancer and basal cell. And it reduced keratosis, these are the precursors to basal cell and squamous cell, by about 15%. And it was only effective while patients were taking the vitamin. It didn't go beyond the period when the vitamin was stopped. And they did make the point at the presentation that, this may be helpful, but patients still need to use sunscreen as the primary way to prevent skin cancer and to regularly see the dermatologist. So what do we learn from this study? This was the first trial to demonstrate that there is effective systemic chemoprevention of actinic skin cancer. So again, this is not about melanoma. And that this vitamin B3 nicotinamide is inexpensive, well-tolerated. Patients really had no side effects. Sometimes people get confused about niacin or nicotinic acid. Those are used to manage elevated triglycerides or fats. And that niacin does have a lot of side effects, but nicotinamide does not. So you can't exchange the two. And I can tell you that there was a ton of publicity about this abstract in the New York Times and many papers. And so patients have already gone out and tried to buy this, and I'm finding that my patients are saying they're sold out at most drugstores. You know, I would say that we're not ready to say that everybody should be taking this vitamin, but there may be patients who've had many skin cancers where this could really be considered. I mean, this is easy to take. It's over the counter. So something to keep in mind and to discuss with your dermatologist. Again, this is not about preventing melanoma, but it's about preventing basal cell and squamous cell skin cancer. Then the second study I wanted to present was a study that was done in Germany. And as you know, patients who are diagnosed with melanoma, if the melanoma is over 1 millimeter thick, or if melanomas are less than 1 millimeter and there are some high-risk features, patients have a sentinel lymph node biopsy. And this is a way to determine if the regional lymph nodes are involved with melanoma. And currently, if a patient has a positive sentinel node, meaning that there was a melanoma in the sentinel node, the standard of care is to do the second surgery to do the completion lymph node dissection. Many patients are concerned about that second surgery because it certainly can add to the risk of lymphedema, swelling of the leg, or risk of future infection. So there are some large studies going on looking at this question: is a completion lymph node dissection necessary for patients with a positive sentinel node? So this study, done in Germany, took patients. Sorry, I'm having trouble advancing my slide here. Shelby, maybe you could try to advance the slide. So as we're working on getting this slide moved forward, the study enrolled patients who have a melanoma greater than 1 millimeter thick. They actually had to screen a lot of patients to find patients who had just microscopic positive sentinel node and who were amenable to going on the trial. And half the patients were treated with the surgery, a completion lymph node dissection, and the other group of patients were just observed.
Dr. Schuchter, can you try it to advance again? There may be something to accept.
No, not on my screen. Okay, good. So this is the trial design. Patients who had a melanoma greater than 1 millimeter thick had sentinel lymph node biopsy, and the study originally tried to enroll over 500 patients, but at the end they enrolled 473 patients. And patients were then randomized, and that's a flip of a coin, to be observed or have a completion lymph node dissection. And in the observation arm, patients also had ultrasound of that lymph node basin to also look for any evidence of early recurrence in the lymph nodes. And so on the next slide, what we learned from this study was that there was no difference in overall survival between patients who had surgery or who were observed. There was an increase in the risk of lymph node involvement in a small group of patients who had the observation compared to the completion lymph node dissection. But in terms of overall survival, there was no difference in this approach. So if I could have the next slide. So there's important practice implications for this study. As I said earlier, the current standard of care for patients who have a positive sentinel lymph node is to have a completion lymph node dissection. There's a 20% risk of lymphedema associated with this procedure. There is a much larger trial that's ongoing across the United States and internationally called the MSLT2 trial that enrolls 1,900 patients with the same design, doing the second surgery versus observation. But we're not going to have results of that trial for a very long time. So these are the results that clinicians are going to have to guide patients on this question. And at ASCO, Dr. Dan Coit, who is the head of melanoma surgery at Memorial Sloan Kettering, was the discussant for this. And he really did think it was reasonable then to consider observation and not do the second surgery in selected group of patients. So I think in patients who are diagnosed with melanoma and they have had a sentinel lymph node, you certainly can discuss with the surgeon whether or not to have that second surgery. So this information is really most applicable to somebody who's newly diagnosed with melanoma. Now, if somebody has many positive lymph nodes, and we're not just talking about micro involvement of sentinel lymph nodes, those were not the group of patients who were enrolled on this study. So the standard of care would still be to do that second surgery. So I think this is going to be important. I think in the future we're going to find that sentinel lymph node mapping is an important staging tool, and gives us important prognostic information. But in terms of it being of therapeutic value, in terms of decreasing the risk of metastasis, I think it's going to prove not to be useful in that setting. And this is what's happened in breast cancer, where breast patients who are diagnosed with breast cancer, they do the sentinel lymph node procedure, but no longer are completion lymph node dissections performed. So this is an example where less may be more, and so that's really good news, because our goal is only to do the procedures on a patient that are really valuable and needed. Now, it's important for me to mention that currently, when we think about clinical trials for patients with positive sentinel node, that's stage 3 melanoma, most clinical trials still require a completion lymph node dissection. I suspect that is going to change as well in the future, but that may influence someone's decision if they're considering enrollment on a clinical trial where this would be required. So I presented this last night also to a group of physicians because I think this has important practice implications. So on the next, then the remainder of my talk, I'm really going to talk about the update on the treatment of stage 4 melanoma that was presented at ASCO. And this included discussions on new targeted therapies and an update on the optimal combination strategies of targeted treatment, as well as a focus on the new immunotherapies. So this first paper was actually presented at AACR, the American Association for Cancer Research, that happened about a month earlier to ASCO. And Dr. Tony Rebus presented a large study known as Keynote 006. And this was a phase 3 trial of pembrolizumab, that's the PD-1 antibody, versus ipilimumab in patients with advanced melanoma. So I think this audience is very familiar with the PD-1 antibodies. These medications work by stimulating the immune system. It particularly stimulates T cells, and the PD-1 antibodies work by basically taking the brakes off the immune system and allows for a fuller immune response. And so the question has been, we know that ipilimumab is effective against melanoma and is FDA approved for the treatment of patients with locally advanced stage 3 as well as stage 4 melanoma. Now we have pembrolizumab and nivolumab, 2 PD-1 antibodies that are FDA approved for melanoma. And this really important question important study asked the question, which is better, pembro or ipilimumab? Next slide. So this was an international study, and patients were eligible if they had unresectable, meaning they couldn't, the melanoma in a regional lymph node for stage 3 was too large to undergo surgery immediately, or patients with stage 4 melanoma. When it says ECOG performance status, that means that patients really had very few symptoms related to their melanoma. Patients with brain metastasis were not eligible. And so patients were randomized to pembrolizumab. This is also known as Keytruda. And the study looked at a dose of 10 milligrams per kilogram. That is a higher dose than what is FDA approved right now, which is 2 milligrams per kilogram. And in this study, they randomized patients to 2 different schedules of pembro, every 2 weeks or every 3 weeks. And then the third group was ipilimumab, given at the standard dose, which is every 3 weeks for a total of 4 doses. And on the next slide, we can see that the overall survival showed that pembrolizumab at 1 year was 74% compared to 58% with ipilimumab. So this is really important because this is looking at overall survival. So this is more mature data. And this clearly shows that in patients with as first line of immunotherapy that PD-1 antibody was superior to ipilimumab. Next slide. So this is a conclusion, pembro more effective than ipilimumab. And important to mention that pembrolizumab has fewer side effects compared to ipilimumab. The side effects from these medications are autoimmune complications. They're called immune adverse events. So when the immune system is stimulated to stimulate the T cells to tackle melanoma, at the same time those T cells can affect normal cells in the body. And so target organs can be the intestines, and patients can get diarrhea or colitis, can affect the endocrine system, the pituitary and the thyroid gland, can cause liver function abnormalities as well as a skin rash. All of these autoimmune complications or immune adverse events are less with pembrolizumab and all the PD-1 antibodies compared to ipilimumab. There was no real difference between the schedule, so giving pembro every 2 weeks versus every 3 weeks. There was no difference there. And results from this trial and others really say that whether patients have received prior IPI or not, pembrolizumab can be very helpful. So on the next slide, this is really the principal take-home message from this abstract as well as another one I'm going to talk about, which is that ipilimumab can no longer be considered standard first-line immunotherapy for patients with advanced melanoma. So ipilimumab, also known as Yervoy, was what we were used to go to as first, and we could only use the PD-1 antibodies after a patient had received ipilimumab, but these data really say we don't need to go to IPI first and we should go to a PD-1 antibody first. So if there's not an option for a clinical trial and your physician is thinking about these new immunotherapies, a PD-1 antibody should be selected first. Next slide. So this was a really important study that was presented at the plenary session for ASCO. And at the plenary at ASCO, the top 4 studies are presented. And so it means that it's a very important study to have this presented in the plenary session. And this was presented by Dr. Judd Wolchok, who's at Memorial Sloan Kettering. And this was a phase 3 trial looking at whether combining nivolumab, which is a PD-1 antibody, with ipilimumab compared to PD-1 alone versus ipilimumab alone would be better in patients with advanced melanoma. And the study design is shown here. So patients with advanced stage 3 or stage 4 melanoma, this is almost 1,000 patients, were randomized to nivolumab, the PD-1 antibody, at 3 milligrams per kilogram every 2 weeks, plus an IPI-matched placebo, versus the combination in the middle, nivolumab plus IPI, and then maintenance nivolumab. and then ipilimumab alone. Now, it's important for me to mention, from a statistical perspective, this study it has enough patients to say if a nivolumab arm is better or worse compared to ipilimumab, and there are limitations to try to compare across all three of these arms. But almost 1,000 patients were randomized to one of these three treatment arms. And what this study showed, and what we have so far, is what's called progression-free survival. And progression-free survival means how long did a patient go without progression of their melanoma. It's not the same thing as overall survival. And this shows that the combination of nivolumab plus ipilimumab, the progression-free survival was 11.5 months compared to nivolumab alone, 6.9 months, versus ipilimumab alone, 2.9 months. So from looking at progression-free survival data, certainly the combination looks to be better numerically, and both nivolumab arms look much better than ipilimumab alone. So the conclusions from this study were that any of the arms that contained PD-1 antibody nivolumab were better in progression-free survival. I didn't show you the data on overall response, but the response rate was also much higher with nivolumab containing arm compared to ipi. And so again shows the benefit of this approach over ipilimumab. Now, one of the important questions is, how do we best identify patients who are going to respond to this treatment? And so this study required a sample of the tumor to look for something called PD-L1 expression on the tumor itself. That's the target of these medications, the PD-1 antibodies. And so there's been thought that if there was overexpression of PD-L1 or evidence of expression, maybe that's a group of patients who would particularly benefit from this approach with the PD-1 antibody. And I'm not showing you the data, I'm just showing you the conclusion. But when they looked at patients whose tumors had greater than 5% PD-L1 expression, the results on progression-free survival of nivolumab alone or nivolumab plus ipilimumab were really almost identical. And if you looked at patients then who had less than 5% staining, there was a suggestion that the combination of nivolumab plus ipilimumab was better than just the nivolumab. But I think at the discussant, Dr. Mike Atkins, didn't think that using PD-L1 expression to determine if someone should get combination versus single therapy was ready for prime time, but sort of intriguing information. Now, this is really important, that when we combine nivolumab plus ipi, there's many, many more side effects. So these immune-mediated side effects were much higher, and what we call grade 3 and 4, which are more serious side effects, happened with increased frequency in the combination arm compared to just nivolumab or compared to ipi. Much more much more colitis, more liver function abnormalities, and more endocrine problems. So I think there's still a lot of concern about the toxicity of the combination, and I don't think there's firm knowledge yet that the combination is superior to single agent PD-1 antibody, in this case nivolumab. We really need data from overall survival to know if the combination is truly superior to single agent. So what did we learn from these studies? Nivo and Nivo plus ipi are superior to ipilimumab, that these treatments, along with pembrolizumab, so these are two different PD-1 antibodies, are the new standards for advanced melanoma therapy. It may be that Nivo and ipi is more effective than Nivo alone, and we're going to need a longer follow-up and additional studies to prove that. That the toxicity of ipilimumab and nivolumab is severe. 36% of patients had to discontinue treatment due to immune adverse events. And we're not ready to say that PD-L1 expression is how we make decisions about using these therapies, and that combination therapy with nivolumab and IPI is not the new standard of care. Could be considered in select patients where a higher response rate is needed more rapidly, in patients who may be sicker with melanoma, and maybe in patients who don't have a BRAF mutation. But I wouldn't say that in a patient who's making a decision today about whether to take immunotherapy that the combination would be the first thing to do. My first approach right now is still to start with single agent PD-1 therapy. So from these studies, I think I've already said this, we now have evidence that Nivo better than IPI. I didn't show you the data, but there was another trial that was a combination of nivolumab plus IPI, which was better than IPI alone. And then we'll see whether this combination is superior to single agent nivolumab. Now, how do we decide? So we have two FDA-approved PD-1 antibodies, nivolumab and pembrolizumab. I don't think there's any difference between the two. They look very similar in terms of efficacy and toxicity. So the choice is really going to be about what physicians are comfortable with, what the schedule is, what the cost is, and we'll just have to sort of stay tuned to whether the biomarker issue is going to be useful in making decisions. I have to say that as a practitioner in this field for 26 years, the activity of the PD-1 antibodies is really extraordinary, with more than 50% of patients having a response to these treatments. And when patients respond, the responses are really durable. We've shared that information with you before on previous calls. There's a higher rate of complete response, meaning all the disease goes away. And honestly, for the first time, we're beginning to use the word cure for patients with stage 4 melanoma, as we're following patients now 3-4 years out from receiving these medications and have no evidence of the disease. So these are truly have completely transformed how we approach the treatment of advanced melanoma. And just for me to mention, so everybody understands this, it doesn't matter about the BRAF mutation status as we think about these medicines. This approach with PD-1 antibodies is really helpful for any patient with advanced melanoma. There are no criteria in terms of a biomarker or mutation status that is needed. It's just, are you well enough? Does somebody have any problems with previous autoimmune diseases? These are how we make decisions about using these medications. So then let me close with two studies looking at targeted therapy. So as you know, in melanoma, about 50% of patients' melanomas have a mutation in a gene called BRAF. And when BRAF is mutated or broken, it's driving the melanoma cells. So the mutation or the broken gene is responsible for melanoma cells growing. And we've had these targeted therapies that basically shut the pathway down, stop this hyperactivity of the BRAF pathway. So this was an update on results that were presented by Dr. Georgina Long and a group of investigators looking at a randomized phase 3 trial of dabrafenib, that's a BRAF inhibitor, also known as Taflunar, with trametinib, which is a MEK inhibitor, that's known as Mekinist, versus dabrafenib alone. And this was first-line therapy for patients with metastatic melanoma. And so the question has been, is it better to use both a BRAF and a MEK inhibitor in combination compared to just a BRAF inhibitor? And that was the purpose of this study. And the next slide shows that about 1,000 patients were screened. 423 patients were randomized to either just dabrafenib plus a placebo versus the combination of dabrafenib and trametinib, BRAF, and a MEK inhibitor. And so there have been a series of these results already presented, and what was presented at ASCO then was this final analysis looking at overall survival. Information that we had before was about response rate and about progression-free survival. And so this first is an update on progression-free survival. Again, that's how long a patient goes without progression of their melanoma. And this shows that dabrafenib and trametinib, a BRAF and a MEK inhibitor, had 11 months of progression-free survival versus 8.1 months if patients received single-agent dabrafenib. And then if you look at further looked at improvement in overall survival with the combination, and importantly, there were fewer side effects associated with the combination therapy. So we see with single-agent dabrafenib and with other BRAF inhibitors a lot of skin reactions, skin rash, wart-like lesions, and skin cancer. And so when we add a MEK inhibitor, we actually see fewer of the skin cancers and fewer skin problems. The only unique side effect of the combination is fever. And this can be really challenging to manage. Temperatures can get as high as 103. It's very important for you, if anybody's taking these medications, to understand that the very slightest hint of a fever, chills come on, you need to hold the medication, you need to call your doctor. Early stopping of the medication and using things like Motrin and Aleve can be very helpful. Sometimes we need to use steroids to manage the fever. But dose interrupting, holding the medication, and then restarting is the best strategy to manage this particular toxicity. So in summary from this study, it clearly showed that dabrafenib and trametinib, BRAF and a MEK inhibitor, is better than single-agent dabrafenib, both from an efficacy perspective and overall better tolerated. And then the second big study that was presented was called Cobram, and this is looking at also a phase 3 trial in patients with BRAF mutant melanoma, and it was looking at vemurafenib, the first BRAF inhibitor, plus cobimetinib, which is a different MEK inhibitor. So this is exactly the same idea, but with different companies' medications. So it's melanoma that was advanced stage 3 or stage 4, and patients were randomized to receive the vemurafenib BRAF inhibitor plus the MEK inhibitor versus just vemurafenib. And then patients were monitored to see how they tolerated the medication and how long they responded to the treatment. And the results showed progression-free survival, again, better with the combination. So cobimetinib, a MEK inhibitor plus vemurafenib, 12.2 months for progression-free survival versus vemurafenib alone, 7.2 months. So these are important practice implications and take-home messages, which is that we now have longer follow-up from these two large studies, that BRAF and a MEK inhibitor better than BRAF alone, that dabrafenib combined with trametinib is now the new standard of care for patients with BRAF mutation, and it's called V600, but it works for both E and K. And it's better because it is more effective and it has fewer side effects associated with it. Now, vemurafenib, is FDA approved, and it's anticipated that cobimetinib, the MEK inhibitor, will also be soon FDA approved. But at the moment, the only BRAF inhibitor and MEK inhibitor that are approved by the FDA is this combination of dabrafenib and trametinib. I mentioned that fever can be challenging to manage, and patient education is key, as we just discussed, and we don't adjust the dose to manage some of these toxicities. More commonly, we adjust the schedule and maybe have patients have drug holidays in order to be able to tolerate the medications. Also, not discussed at this meeting, but when we think about more intermittent schedules, we're not concerned about not having somebody on a medication every day, because we do think that an intermittent schedule may be a better strategy to use these targeted agents, and maybe we would see less evidence of resistance if we used more of an intermittent schedule. So we're not concerned about holding doses because of toxicity. In fact, there are clinical trials that are ongoing looking at whether a more intermittent schedule of these targeted therapies would be better than using something every day. So really where we are on this slide here shows these really remarkable advances in melanoma over the past 4 to 5 years, with a series of clinical trials that begins to show how these new therapies fit into management of patients. And in the bright green boxes here on the right are really what we learned at this ASCO. Pembro, PD-1 better than IPI, this combination superior to IPI. Maybe this combination is going to be better. We're going to need to wait and see. And this the combination of BRAF and a MEK inhibitor better than single agent BRAF inhibitor. So a lot of advances in the management of patients with advanced melanoma. So the summary from ASCO and AACR is that sort of the top papers that I've selected, that in patients with sentinel node positive melanoma, perhaps observation could be considered rather than completion lymph node dissection. This can be discussed with your physicians, and adding ultrasound monitoring of the lymph node basin. That ipilimumab is no longer first-line therapy for metastatic melanoma, but that the PD-1 antibodies, either pembrolizumab or nivolumab, is the treatment of choice for first-line management of advanced melanoma when selecting immunotherapy. And that when we use targeted therapies in patients with BRAF mutant melanoma, a combination strategy is really superior to single-agent BRAF inhibitor. So what are the next steps going forward in terms of immunotherapy? Whether all new studies are going to use both PD-1 and IPI and then have triple therapy or doublet therapy is, I think, unknown. But there's a lot of other immunotherapies that are being out there and explored, including GM-CSF, the IDO inhibitors, OX40 and LAG3. So these look like interesting agents that may also work with the immunotherapies. New life, I would say, in vaccine strategies, particularly as we think about combining PD-1 antibodies with some of these medications. And interesting data combining radiation, this concept we're pursuing at Penn and other places, this concept of RADVAX, radiating the tumor and giving ipilimumab or PD-1, and studies looking at anti-VEGF, which affects new blood vessel formation in cancer cells. So a lot in terms of building on what is already a really remarkable activity of some of these new immunotherapies. And then for targeted therapies, today we focused on BRAF mutant melanoma, and so a lot of strategies now saying, you're all aware that over time, patients become resistant, their tumors become resistant to the BRAF inhibitors, and there's many different mechanisms why resistance occurs. Different pathways in the cancer cell become activated. And just like when we give antibiotics to patients with a bacterial infection and the bacteria become resistant, the same thing happens with the BRAF targeted therapies. And so a couple of different strategies. Do we use the BRAF and a MEK inhibitor and add a medication up front to prevent the development of resistance? Or other strategies are use these combination strategies at the beginning, and when resistance occurs, add a third drug or make a switch. And these are some of the pathways that are being pursued: the PI3 kinase pathway, anti-VEGF I've mentioned, CDK4/6, c-MET, FGF, fibroblast growth factor, autophagy, etc. So there are many, many new drugs that are targeting these other pathways, which we think is going to improve the overall benefits for targeted therapy. Now, of course, the question is going to be combining immunotherapy and targeted therapy. And so there are strategies now and studies exploring doing both things at the same time. and many of you out there may be a candidate for some of these studies that look at should we do these things at the same time, or is a sequential strategy the most effective. I just want to call your attention to a new study that's going to be opening in ECOG and across the United States. And this is for patients with BRAF mutant melanoma. And the question is, do we start with immunotherapy or do we start with targeted therapy? And so this study really looks at this question of starting with giving IPI and nivolumab versus giving the targeted therapies, and at the time of progression, the patients are switched. And so this is a really important study because we don't know in patients with BRAF mutant melanoma what's the better thing to do. Do we start with immunotherapy or do we start with targeted therapy? Always, 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 I would say, ask your doctors about clinical trials because this is where we're going to continue to make these incredible advances that we've seen over the past several years. So to end, I know that was a whirlwind of information. I hope you have found it valuable. There's other prior conferences that are also on the MRF website that can give you some of the background information to what we talked about today. But I think it's great that MRF, the Melanoma Research Foundation, every year does support this program to give you the latest information about new treatments. Shelby, did you have any final comments?
Yeah, thank you, Dr. Schuchter. That was fantastic, and you know, a great thank you to you for providing this update for us every year. I know it's always very appreciated among the patient community. So thank you very much. Our webinar is now concluded. Any questions about this webinar or topics that you'd like to see in the future can be emailed to me at education@melanoma.org. You can also visit our website to see those recordings and other recordings from in-person events at melanoma.org to learn more and keep current on all that's happening in the melanoma treatment and research landscape. So I want to thank you for participating in this webinar, and thanks again to Dr. Schuchter.